Okay, so good afternoon, everybody. Thank you very much for joining us today. This is mental health. This is about the regional learning that we've all got from COVID. So thank you very much for being there. Thank you very much for joining us. And just in case I forget at the end, thank you very much for all the speakers. And also a big thank you to Dave and Jen for pulling this together. It's very much appreciated, and it's also very well received. Will be very well received by all of us. So thank you for that. Few housekeeping issues at the beginning, I'm afraid. Could you please turn off your cameras and your microphone unless you're speaking? Session will be recorded, hence the red button in the corner. They will make a copy of this available to anyone who requests it over the next week or so. Also, please use your Q&A, the chat boxes. If you use the chat boxes, that would be very much appreciated. Jenny's in control of the chat box, so she's really going to provide timely, comprehensive and robust feedback and answers to any questions that you've got. If not, we will be putting together a document at the end of this for you all to take away and share, and that will be distributed over the next week or so. I intend to run as close to time as possible, so please do use the chat box to avoid anything that may harm that. With that in mind, I'd now like to go to our first speakers, if that's possible. First topic is about understanding acute mental health presentation during COVID-19.
Jay, are you there?
Do we have a mute issue?
Sorry. Yes. Sorry, I just forgot to unmute. I'm going to start again. Sorry about that. So this will be a joint presentation between myself and my colleague, Dr. Kunigiri, who's also a clinical director. My name is Dr. Srinivas. I'm a clinical director for West Midlands Mental Health Clinical Network, and this is to help understand acute mental health presentations during COVID. Can I have the next slide, please? Thank you. So we undertook this project based on reports from frontline clinicians, and they reported that they were noticing an upward trend in presentations during the COVID period. This was not initially, but after the initial sort of month or so, that gradually noticed an increasing trend. And they felt that this was putting an additional strain on already stretched inpatient resources, on urgent and emergency care pathways, and also because things were being handled remotely, it was also putting pressure on Mental Health Act procedures within provider services. They also reported that the increased presentations they were seeing included both patients known to services, and also there were a number of first-time presentations to mental health services. So we wanted to get a deeper understanding of this. So in order to do that, we mapped out a sort of a methodology which was aimed at capturing the impact on acute mental health services, their counterpart, which is the community mental health services, and any mental health pathways into care. And we actually wanted to impart the learning from this exercise to support recovery, restoration, and reinstatement of services from across Midlands. Can I have the next slide, please? So this is the methodology we used. We wanted to have a combination of quantitative and qualitative methods, and also use focus groups, because we were running several webinars engaging frontline clinicians from across Midlands at the time. So the quantitative aspect was we thought we'll gather sample data on admissions to all mental health wards, including psychiatric intensive care units. And we decided to gather that data from 2 organizations across Midlands. One's Leicestershire Partnership NHS Trust and the other's Midlands Partnership NHS Foundation Trust. And we wanted to gather the data across 3 months, which is March, April, and May from 2020. And we wanted to compare this data with the same period in 2019. Also, we wanted to pull out 20 random cases from that across both sides, and we wanted to undertake a further analysis of those to understand the impact of COVID and understand those patients' access pathways into mental health care. We also ran focus groups. We ran 3 engagement events involving around 80 participants, and this included frontline clinicians, service managers, CCG commissioners, and these were all held during June 2020. And what we wanted to do using these focus groups or webinars was we wanted to improve our understanding of why these patients were presenting to services, and also we wanted to find out how we can put mitigations in place to improve service provision and service delivery as part of restoration and recovery. Can I have the next slide, please? So this is the quantitative data. So this is the quantitative data, and what we found was that the majority of the increase in patients were actually those who were not previously known to mental health services, and nearly 50% of those were due to psychosis. So the highlights are these. As you can probably see, the admissions increased by about 12%, like for like when compared between 2019 and 2020, and as you can see, 32% of those that increase was first presentation, and only 2.8% were previously known to services. And in close to 50% of the cases, the diagnosis was psychosis, and in about 18% it was non-psychosis. What was also staggering was 84%. There was an 84% increase during this period, that is 2020 compared to 2019, in admissions to psychiatric intensive care unit. So what we kind of deduced from that was the acute nature of these presentations requiring an ICU bed. So if I can have the next slide, please. And also at this point, I'd like to hand over to my counterpart, Dr. Kunigiri, who will take you through the rest of the presentation. Thank you.
Thank you, Jay. Thank you all for allowing us to do this presentation. I mean, going on from what the other results show us, in terms of the case analysis for these 20 patients, 10 from each Leicester and also from Birmingham, it showed that out of these 20, 12 of the admissions were directly or indirectly related to COVID-19. It's not surprising that patients with mental health problems during COVID period experienced high degree of social isolation, lack of daily structure, and also increased anxiety related to the COVID and paranoia. And although there was virtual support to most of our patients, even during COVID, there was one, patient's pathway which suggested that lack of community support possibly contributed to his admission to the acute ward. With regard to the results from the focus group, which was mainly by the clinicians, commissioners, and the providers, they concur some of the results from the qualitative analysis in terms of anxiety and fear, and also the psychosocial stresses which have contributed to admissions. But what was also interesting is that the clinicians felt that during COVID period, lack of voluntary services and the adequate social care support, plus closure of the key community facilities like the shops, libraries, did have a significant impact on our patients. And majority of young people had psychotic breakdown, and they all had some significant stresses during this COVID period, which was a bit more than usual in terms of job losses, relationship breakdown, and also increase in substance abuse. We all went for virtual world, and clinicians did feel that lack of face-to-face contact and increased waiting times to be seen by the specialist and other professionals contributed to the admissions. Next one, please. I think there is a little bit of a delay in terms of the slides moving, I guess. Okay, thank you. During the COVID, it is not surprising that there was significant anxiety and nervousness among our patients, like any other general population. But what was interesting from the clinicians that they didn't feel that COVID per se or the treatment for COVID-19 contributed to relapse of any serious mental health problems. As it is very known that during this period, along with general population, many of the patients with mental health problems were afraid of going to health services, particularly to the A&E or even to their GPs, because of which there was delay in accessing the services, and probably this would have contributed to the acuity and rest. And because everyone went to the virtual world, and also there were some significant changes in terms of how psychiatric liaison services were set up, such as the urgent care hub in some places. There has been some views among the stakeholders that there was possibly increase in 136 suites and admissions, because of the changes, which was not, well informed to our patients. Next one, please. Yeah, so what we suggested in terms of the views, what we had collated is that, to help in terms of managing some of this acuity, it is important that we all work together at system level to restore community resources as much as possible. I know that social distancing is extremely important, and also to go through the infection prevention control for COVID-19. But we need to collectively look at stepping up to see how we can provide the services, both statutory and non-statutory services. There was also similar emphasis on community mental health teams, so that particularly patients who have acute mental health problems, they do have access to face-to-face meetings along with digital consultation. There was also a call to enhance the continuity of care, both between the inpatient services, both for mental health and medical inpatient wards, and also to the community mental health teams. I'm sure that all the STPs do have the digital strategy, and it is quite important that this is an opportunity for us to bring forward some of the key elements in terms of communication between various stakeholders using that. We know that during the COVID period, there was no adequate time in terms of discussing with different stakeholders in terms of the changes, particularly with regard to the urgent care hub. There was some concerns by some of the clinicians that having urgent care hub away from acute A&E care, although it has lots of merits, we also need to think through, how this would affect in terms of the patient's pathway, and also in terms of the stigma and the medical health issues SMI patients can have with us. Next one, which I guess would be the last slide for us. What was very clear is that patients really appreciated having this 24/7 helpline. I think STPs needs to really support and strengthen the helplines which were done in most of the areas during this period. And as I initially suggested, that a system-wide approach in terms of pathway development is very important when we are developing any new service in terms of restoration and recovery. It is important to see how that service will have an impact on other services and what the interdependencies would be. And the third is in terms of adequate clinical engagement, along with engaging other stakeholders. I know that due to ICC, there was not adequate room or time for detailed consultation, but it is important that in terms of moving forward, this is something which we definitely consider. And the last one is, in terms of restoration and recovery, we don't have enough evidence-based approaches. What would be the best? I think it is important that, everyone involved in this care did emphasize that clinically led action learning set approach was the best way, so that we take into account what experience the patients and the clinicians have in terms of managing. And this forum is a very good example of using those feedbacks from you all to help us to move forward. So I'll stop here, and I'm sure me and Jay will be happy to take some questions. Thank you.
Thank you very much. That was excellent. Please direct any questions to the chat box where Jen is in control of it, and she'll be able to action any of the questions that are sent. Also, she will put together the full listing within the next week or so, I believe it is. I'd like to invite the next speaker, please, to talk about the different perspectives on the impact of COVID-19 on mental health service provision and use.
Hello. Can you hear me okay? Oops. Hopefully you can. Hi, it's great to be part of this event. I'm Dr. Joanne Inman. I'm from Cheshire and Wirral Partnership NHS Foundation Trust, and I've come today to really share a programme of research that we've been working on, which is about looking at different perspectives on the impact of COVID-19 on mental health service provision and use. And really today is some kind of just letting people know what we're doing, where we're up to with it, and some of the emerging findings that are coming out from the work. The project team is also here, and the project is led by Professor Taj Nathan, who is a consultant psychiatrist and also the Director of Research at CWP. Can I have the next slide, please? So just a bit of an introduction to what we were aiming to do and what our vision was really. CWP is a trust which provides mental health, learning disability and community physical health services. And one of our core values is about working in partnership with all stakeholders to provide high quality person-centred care and to really embrace research and innovation to enable us to do that. So this is very much by this programme of research is looking at different perspectives on the impact of COVID-19, because we think that will give us a fuller picture of what's actually been happening. So what I'm going to do now in the presentation, I'm going to talk to you a bit more about what our aims and objectives of this programme of research are and were and are, what we've progressed with so far, some of the kind of high level emerging findings and what some of our next steps are going to be. Next slide, please. So the overarching aim of the programme really was very much to look at and understand the nature and the effectiveness of changes in service design and delivery across the trust. And this is in response to COVID-19. And this is very much because, as I'm sure everyone is aware, suddenly due to the pandemic, things had to change rapidly, and we really wanted to gain insights about what had changed, how can we use that to inform future service provision and future kind of crisis planning. But also there was a huge amount of innovation and initiatives by staff members and teams, and we really wanted to learn from that and reflect on that and really incorporate the most successful new ways of of working into everyday practice. Next slide, please. So our project objectives. We wanted to describe and understand the nature and the effectiveness of the changes in service design and delivery across our services. And we very much wanted to look at this from different perspectives, as in from service users who use our services, from staff perspective who are providing the services, and also from a range of staff within the organisation. And we wanted to do this from looking at quantitative data in terms of actual service utilisation across the whole period. So what was service utilisation like pre-pandemic, and then at weekly time points throughout it. But also very much alongside that, to do really a qualitative exploration of what was the impact on mental health and on service provision during this time, from a very kind of practice service provision perspective, whilst also really needing to consider that when we're looking at different perspectives, that also includes a whole plethora of other staff working within the trust in other roles and settings, which is not necessarily kind of front-facing clinical. Next slide, please. So the programme of research involved a number of different elements to it, and it's still ongoing at the moment. And this is really a bit of a kind of progress update as to where we are with that. So first of all, we wanted to really explore and understand the changes in service design and delivery. And so we facilitated 9 focus groups, so there's 38 contributors in total. And those focus groups were really with staff at all levels within the organisation. And what we wanted to learn from was what was people's experiences, what had gone really well, what could go even better. And that analysis has been completed, and I'll share some of those kind of high-level results later. The other thing that we did across the trust is we used a clinical prioritisation tool in different kind of care groups, whereby it helped us to understand each individual service user's needs, risks, and how we were going to engage and work with them through the time of the pandemic. And so we did a survey to staff about the use of that tool, how effective, what we thought it was, what had gone well, what could go even better. And that initial analysis is also completed. So we've kind of staggered the start of different programmes of research. So that one's kind of well on its way. Another really, really important one for us, especially in terms of kind of future demand and capacity modelling, was really to understand the changes in service utilisation. There's lots of talk in the news about people not accessing services because they were concerned about the risks to themselves. So we really wanted to understand this in more detail. So we're working in collaboration with the University of Liverpool to very much look at the data in terms of service use, and that information is shared with them now, and they're undergoing that analysis. So we're really excited to hear what they found out from that. We also have done a survey of all staff across the organisation, because, like I said before, we wanted those different perspectives on our response to COVID-19. We've got 848 responses back, and we're starting on the journey in terms of the data analysis there. And then fourthly, a bit more complex in terms of gaining ethical approval, we really want to interview practitioners as well, but that's in the process of getting ethical approval. But we have surveyed 321 service users as well about what their experiences have been, what's worked well for them, what could work even better, and we're trying to feed that into our everyday ways of working. Next slide, please. So preliminary results. We've got the preliminary results on the clinical prioritisation survey and the focus groups that we've done with staff at different levels. Next slide, please. So this is very high level representation of some of the themes that have come out from looking at staff's experiences of kind of urgently adopting digital technology to work with the different individuals that we work with across the trust. And like I referred to before, we had a prioritisation tool, clinical prioritisation tool about how we were going to work with people and the use of digital technology. And just to kind of give you some high level feedback from that, really at the centre of decisions around that was people's concerns about the quality of the contacts, whether they could use digital technology effectively. So that's in terms of interactions with people. Could we kind of interact? And there's quite a different experience of working in children and young people's care groups to working in the community with more elderly patients. The quality of contact there was concerns about observation and examination. Did you really get the whole picture? And in terms of the quality of interventions, because suddenly we're kind of changing to provide them in a different manner. Connected to the quality of the contact was that, you know, not everything could be delivered by digital tech. So there needed to be contingency plans in those scenarios. There were concerns about safeguarding that perhaps wouldn't be picked up the same on a face-to-face intervention. Interestingly, and I don't know if others have found this, multi-agency working actually became a little bit easier because the speed at which you could get people together in one virtual meeting actually was quicker. And a key aspect of this was around availability of the digital technology as well, not just for staff, but also for the service users that we were working with. Next slide, please. So these are kind of some of the learnings that we're taking from that and thinking about incorporating in terms of how we provide our services, that we really recognise that remote consultation can facilitate greater accessibility and actually in some instances more frequent contact. We recognise that dedicated training should be considered to particularly improve assessment and intervention skills because it's not being readily provided in this manner previously. There is a learning that remote consultation should be seen as part of the assessment and the intervention, but also to be aware that face-to-face does have its advantages. We also think that it's from the kind of themes that came up, that more widespread adoption of remote contact also needs to really very much include kind of clear contingency planning, especially when there's risks concerned. And I think, like the previous presentation said, that kind of going forward, it really needs to be, the next steps need to be kind of explored and discussed in collaboration with really service users and other agencies as well. Next slide, please. And so this is some of the high level themes from the focus groups, and from the focus groups which talk to staff at all levels through the organisation. One of the key themes in terms of how people responded during the pandemic, there was kind of domains of change which were really important. So how communication, decision making, relationships had strengthened actually, because people were having more contact with one another and with different people. There was practice changes. There was in lots of different areas, at a service level, at an individual level, at a team level, and there was a huge shift change in terms of information technology. So those are kind of the overarching themes that came from the focus group. Next slide, please. I'm sorry, this hasn't quite come out as it looked, this PowerPoint, when I sent it through. So I promise the words were actually in the circles when we did it. So anyway, so we have the domains of change, which is kind of those overarching areas of what enabled people to respond during COVID-19. And then we actually had the mechanisms. So how was change happening? How were we responding to the different needs that we needed to at this time. And there was an aspect of that about responsiveness and adaptation at a different scale to what people have been used to doing in their routine practice. So it's a bit like, right, okay, well, that's the issue. What can we do about that? How can we make a decision about that today? Can we adapt it? So it was very much a different kind of mindset. Another mechanism for change, kind of purpose and commonality, and this particularly not just within teams, but also working across the system as well, that there was a real clarity in terms of a shared goal. So everyone was like, this is the goal, that's what you can do, that's what we can do, that's what they're doing. And that really seemed to help people to make decisions quicker and with more focus, to kind of prioritize what do we need to do today, what can we leave till tomorrow, what do we really need to talk about face to face. So that kind of common goal was really strong. There was also a real theme around innovation and creativity that people were experiencing and doing on a daily basis. So this is a challenge. How might we do that differently? How might we do that more efficiently so that we can still do all these additional things that we need to do at this time? How can we still connect with this person? How can we provide this intervention differently? What about the people that we're most concerned about? And there was a change in the way that meetings were facilitated within the organisation, and I think that people felt that by doing it through digital technology, they were more efficient, they were more timely, and that by there being more kind of shorter meetings that kind of got to the point or really prioritise what the key important things were, people seemed to feel like they had more autonomy and they were free to act, so that they had the time to really do what they needed to do. They were getting decisions back from a concern in a service within a day, rather than waiting maybe for a monthly governance meeting. So it's fascinating. I mean, this is obviously just kind of the high level themes at the moment. Next slide, please. And this is the final slide. So our next steps is we're still kind of working through the different studies that we're doing. We have to gain ethical approval for interviewing staff. We need to complete the data analysis, and then we are hoping to disseminate the findings and submit them to peer-reviewed journals and conferences. And thank you for your time. If you have any questions, feel free to contact Taj and Lauren, who are leading this programme of research.
Thank you very much. That was excellent. Please also use the chat room, which I see is working its way now. Our next speakers are here to talk about mental health, urgent care hub as an alternative pathway for patients presenting with COVID-19. Thank you.
Hello, thank you for inviting us to speak. It's going to be myself and Romeo who will be talking through this. I'm the business manager for the Directorate of Mental Health at Leicestershire Partnership NHS Trust, and I've got my colleague Romeo who I'll let introduce himself.
Hi, I'm Romeo, the Senior Mental Health Practitioner stroke Advanced Clinical Practitioner for the Urgent Care Hub.
Okay, next slide.
So the Urgent Care Hub, we set it up more in response to the COVID-19 pandemic, and our aim really was to look at, I'm having technical issues that the slide hasn't moved, but okay. If you just provide the next slide,
Romeo.
Sorry?
I think you've jumped ahead, Romeo. Do you want me to do this
one? Right.
That's okay.
I'll step out.
That's okay. So as Romeo was saying, we were asked to look at, as part of the COVID emergency response locally, around how we could try and divert as much traffic away from A&E as possible, and also try and release ambulance and police crews quickly so that they could move on and deal with the sort of pandemic situation. So we looked to set up an extension of what is our mental health triage team, or our liaison team in A&E, to an alternative site. And actually what we found is there's been some additional impacts of that. So we've reduced our out of area to 0 with support of the new hub. We've seen a significant reduction in length of stay because of improved gatekeeping. And we've also had really significantly improved working with the crisis resolution home treatment team. I think because within the hub they're identifying daily patients who can be treated at home, whereas I think previously if you've had a junior doctor, for example, in A&E assessing somebody, they've perhaps recommended admission. We've also had quite a focus on timely identification of barriers to discharge. So because we can hold somebody in the mental health urgent care hub for up to 3 days, we've been able to work on barriers that might enable them to have treatment at home. So we've prevented admissions through that way as well. We're also working towards a trusted assessor model across the urgent care pathway. And we've introduced an acute liaison service in terms of Core 24. Next slide, please. Okay, Romeo.
Hi, thanks, Sam. So as Sam said, we obviously set up this more as a direct response to the COVID pandemic that we had. And the aim was to look at diverting patients away from A&E. When we sort of set up, this also included sort of CAMS input. So we had CAMS workers working within the urgent care hub. Though we used the same entrance into the hub, but the young person team would use the same entrance, but there was an allocated place just for the young people to be seen and have their own waiting area. And we more or less looked at people that would normally present within A&E for just sort of routine urgent mental health assessments. And we also had the ability to look at people that had self-harmed and had taken minor overdoses but not require intervention. So we're able to provide ECGs, bloods immediately for if someone turned up, they'd taken a minor overdose. If they'd self-harmed, we're able to offer suturing, gluing and treating the wounds, and then offer a mental health assessment after that. The hub was sort of set up with quite a lot of experienced staff that were redeployed from other services within the trust to work in the hub, and all of the staff that sort of came to work at that time had quite a lot of expertise in triage and assessment. And then looking at our staffing model of the mental health, we've got mental health practitioners, advanced nurse practitioner, healthcare, and we also have sort of medical input where our CDR doctors are based within the mental health urgent care hub. Most of our referrals came from the ambulance service, 111 and A&E itself. Some GP practice is also sort of referred into the mental health urgent care hub, and also other teams within the trust, especially our new central access point service. Next slide, please. So in the mental care, we looked at sort of shared medical and nursing leadership across the pathway. We looked at a joint approach across the acute liaison service and worked closely with our colleagues within A&E at that time, because our A&E was a red zone. So if a person sort of presented in A&E, didn't require medical intervention, then A&E would work with us, make a sort of refer the patient to us for assessment. It also sort of, we looked at the urgent care hub as it is now, as Sam has explained earlier on. We have a facility to allow patients to sort of stay with us for a maximum of 3 days, where we have looked at sort of like sleeper beds or chairs that we have. And currently, we've just finished looking at our alcohol pathway, and we'll be working quite closely with our service providers for alcohol and substance misuse within the trust, which is Turning Point. Also, what we've also found is that our staff are able to offer sort of like a holistic assessment, allowing crucial carer involvement and risk assessment. We've been able to develop safety plans for the patient. So if we're to assess a patient in the mental health urgent care hub, we would develop a safety plan, which, if, for example, if they're going to go to the crisis team, they would have that safety plan between the urgent care hub and the crisis team. Sort of to date, we have had about 1,229 referrals since we launched in March. And our central access point, which also refers into the urgent care hub, has had about 562 referrals. Currently, we work on a model of having 2 mental health practitioners, 2 healthcare support workers per shift, 24 hours, 7 days a week. And we have the ability to take up to 24 patients within a 24-hour period. Next slide, please. So in terms of the impact of the mental health urgent care hub, it has improved patient and staff experience. If we look at the patients themselves, following what we had quite a lot of patients give feedback into the urgent care hub, and we found out that a lot of patients who would have ordinarily gone to A&E would have got to A&E, seen a general nurse, then waited to see the mental health triage team. So that could be about a 4-hour wait before they were able to see a mental health professional. Whereas with the urgent care hub, they are brought in by ambulance. Within 15 minutes of arrival, they've had their observations done, and a mental health practitioner is doing an assessment. So reducing their wait time in terms of accessing services or help. We also looked at, we also saw there was a reduction in rates of admissions, less referrals to inpatients, because when someone was referred for an admission, they would come to the urgent care hub for an assessment, and which, comparing to our mental health triage team, which is based in the A&E, we're able to look at a reduction of about 2% of patients being referred for admission, as we were able to assess and offer either crisis intervention at that time. Positive impact in terms of our partners. We've had quite a very good feedback from EMIS, which is East Midlands Ambulance Service. They have been able to sort of bring patients to us, and at one point, even when I was on shift, we had paramedics come 6 times back to the urgent care hub with 6 different patients, something that if they'd been going to A&E, they would not been able to do, as a visit to A&E would have lasted maybe up to 2 hours. The police also have found the urgent care hub quite helpful, as again, if they have someone that they're concerned about, they were able to ring the urgent care hub. So instead of placing this person in a 136, they would speak to the urgent care hub, and the patient would be brought to the hub for the assessment. We've also found that this created less pressure on staff in terms of quick clinical decisions. So this allowed us more time for sort of senior or medical input. So when ordinarily you'd have a patient coming in quite distressed and staff are sort of stuck with the only option being admission, the urgent care hub, we've been able to keep patients off for 24 hours, allowing the next day for the consultant to sort of come reassess the situation. It's also sort of allowed us a seamless transaction within the crisis team, as we work quite closely with our crisis resolution home treatment team. And also we work within our integrated bed management process. So all informal admissions, before they're admitted into the Bradgate, they would go through the mental health urgent care hub, and of the 42 or so referrals that were done for informal admission, only 2 were admitted and 40 were managed within the community and did not require hospital admission. Next slide, please. I'll pass it on to
Romeo. So as Romeo has explained, we've seen quite a significant impact from the hub on a number of different areas. I'll just take you through a few, just some statistics to give a bit of context, really. We've looked at the referral sources. So We do have self-referrals that come through, and they are through our central access point. So as part of COVID, the emergency response, we set up a central access point which can take calls from the general public who want to self-refer, and the CAP can then obviously advise people to attend the urgent care hub. We get a number through police where they obviously attend at scene, and we have a mental health nurse triage worker that has sat in a police car as well, so we get them through that route. We also get referrals from primary care and general practice. Majority of them come via EMAS and A&E, and we also get the CAP and also from the crisis team as well. Next slide, please. We've also looked at where now our sort of peaks and troughs are in terms of the hub. When we set this up, it was a bit of an urgent response and there wasn't a lot of time for planning. So it's been really interesting to look at when our peaks are. And you can see from the information, it's a bit small on the slide, but you'll get copies of these, that it's pretty equitable across the days of the week. And we do see a sort of a peak in terms of sort of early afternoon. We've also seen it generally increasing in terms of the uptake. So what we have seen is that it's had a really positive impact on our A&E attendances. So it is having the desired impact in terms of preventing pressure on A&E at the moment. Next slide, please. I don't know if there's a technical issue. Could we have the next slide, please?
It should be there.
It's still saying the same information. There we go. That's great. Thank you. So what we've also looked at is where people go once they've been to the hub. So discharged, admitted elsewhere. We're looking into that, but I think that's where they've potentially had to go back to A&E, but I think Romeo will be able to talk a bit more about that. The majority of our patients actually are discharged back to primary care, but with community support packages in place. Some of them are discharged to the CMHT because they're potentially already known to us. We do get a proportion that are assessed but don't actually need any further ongoing treatment. And a very small proportion are actually admitted to the ward, only 3%. Next slide, please. What we wanted to look at was the impact on our admissions, and actually what we found is it's really positively impacted our admissions rates. Just in terms of context, this time last year we were one of the worst performing trusts for inappropriate out of areas, and actually we've sustained a 0 position since March, and part of that is down to the impact of the hub on preventing unnecessary admissions. We've also seen the proportion of informal admissions reduce as well, which is really positive. Next slide, please. I'll hand over to Romeo for this one.
Thank you, Sam. So looking at the hub where we've had stuff like our partner feedback, the crisis team, not just, obviously they were quite overwhelmed during the pandemic, where as quite a lot of services were closed, there was no community input. So the crisis team was quite overwhelmed. So we were able to also work alongside with the crisis team and take quite a chunk of their work. So the people that they were supposed to have assessed were seen and assessed in the mental health urgent care hub. I mean, if you just look at the sort of the feedback from the staff, crisis staff, Leicester Police, EMAS, Leicester Triage Car Officer, and in terms of the actual staff experience themselves, was quite positive, and which was one of the things that sort of drove us to sort of continue offering this service and work throughout the pandemic, which we did. Next slide, please. Hello, next slide, please.
Apologies for the delay, Romeo. It is there. It's just obviously not come through to you yet.
Okay, so what we did was we sort of, after following an assessment, we have our feedback forms that we sort of give patients and carers when they come, and a high proportion, if you look at it in percentage, 99% of our sort of feedback has been extremely positive. Something that we were able to actually address and bring to our staff board meeting following, where we sort of collected. We still continue to collect staff feedback following each assessment. In terms of our staff feedback, we look at the experience that they've had in the hub. One of the biggest issues was wait time, which in A&E was quite long. You'd have patients waiting up to 6 hours to be seen by a mental health professional. So our feedback, which we still continue now, has been very good and excellent throughout. Next slide, please. Again, we also looked at staff feedback. These were either staff that work within the urgent care hub or staff that referred into the urgent care hub. And again, the feedback was quite very good. Not only did the urgent care hub sort of create quite a lot of opportunities for staff, because we were able to look at some of our, because it was made up of staff that came from sort of everywhere around the trust. So some of our staff were not sort of quite up to date in terms of doing assessments on a daily basis. So that we were able to sort of monitor the staff in terms of doing assessments. We'd sit with staff whilst we're doing assessments, and now we've been able to create a staffing where quite a lot our staff are quite competent. We've been able to create opportunities for junior staff that were either band 5s, and they're now looking into band 6s. So again, our staff feedback was quite excellent. Next slide, please.
Do you want me to pick this up, Romeo?
Yeah.
So I won't go into it because obviously we're running out of time, but just to say that the response from our partners, police, the hospitals, ambulance crews, has just been overwhelmingly positive, and have really sort of pleaded with us to continue this. And there has been commitment now that this is here to stay, which is really positive. Next slide, please. This just summarises the areas that we wanted to develop in terms of the feedback that we'd received. And obviously what we're looking at is for people that are walking in sort of on foot to A&E, it's how do we divert before they even walk through the doors so that we can prevent people having to go through sort of layers of assessment. I think the key learning for us has been that obviously we've come up with a model that's all age, which for our organisation was unheard of previously, and it's been a really positive culture change for us. Having combined mental health and physical health, and having one assessment rather than layers of assessment, full MDT, actually having that senior medical input at all times has really helped in terms of reducing admission, and having sort of collaborative care planning with patients and carers at that point of time, and that they go home feeling confident that they're safe. Next slide, please. That was it from us. Thank you. Thanks for your time.
Thank you very much. That was excellent. Continue the theme of mental health and the hub. now like to bring forward our next speaker to talk about integrated mental health. Just to point out, though, we are slightly running over time, so I may give you a 2-minute warning so that we can try and get back on track to finish at a sensible time. Thank you very much.
I'm guessing that 2-minute warning will be in about 3 minutes' time. So that's fine. Hi, everyone. It's Adam Smith, Assistant Director for Northamptonshire Healthcare Foundation Trust. Jen's not with me today. She's had to pop off and do something else. So I will take you through the next few slides. And I've only got 4 slides, so I won't keep you too long. But really the ask from us today was to talk similarly about what we've done in the way of an integrated response. I guess slightly different to what you've seen from Leicester there, which is a fantastic piece of work. Our response had to be slightly different in our area because our service users and carers said they wanted something different from us, and we'd been planning our response, I guess our 24-hour, 7-day-a-week phone line and response hub for a couple of years prior to NHS England saying that we had to have one through the COVID situation. So we were in a better position in that respect. We had an opportunity to ask our service users and carers what they want. We had an opportunity to play on the skills and experience that we'd got through developing crisis cafes and crisis houses and other lower tiered services that allowed us to develop a different style of model. Neither one being the right model necessarily, but it has to be particular to your area, I guess. So that was the ask that we had. So next slide, please. The painful delay. So I guess our version of the integrated part of the response hub, we initially thought about our response being slightly different. We've kept our operational boundaries around our crisis teams and crisis services almost where they are within the trust, but actually we've tried to manage this left shift across to meeting service users much earlier within their community and much earlier within their crisis as well. So we've developed a needs-based model that's less about psychiatric crisis and more about just being there at the point of contact. So it's a self-referral point. As I say, it plays on our crisis cafes. It works directly alongside our third sector, and it's developing with our social care partners as well. And very much the want of our phone line and our response hub was always about being able to answer the question that was asked of us at the time. So if a service user rang up and just said that they were concerned about their mum and their mum's mood, then that would get the same thorough response as if someone rang up and said that their loved one or themselves were in a psychotic crisis or they felt suicidal. Because at that point, that person's need is the same. And it's not for us to decide what that need is or what level of need that is. And we spent a lot of years as NHS organisations deciding. Someone would ring up and say that they were in crisis, and we'd say, well, you're not really in crisis, ring back when you are. And then we'd ask them to ring back when they were big ill. And eventually they'd get big ill and they'd go to A&E, and then we'd try and scratch our heads to work out why. So this was very much about us trying to get there much earlier and work with people at that point of contact. So what you'll see in our integrated hub is it's predominantly a phone-based model, although it has spokes from it, and I'll talk about those as we go through. We've got a 3-tiered model in that we've got a base in one area of Northampton which has our phone line, and then we've got satellite bases in our borough council offices. We will have one once COVID's out of the way. We've had to cut our cloth a little bit, but we've trialed those, and we'll have navigators in our borough councils. And then we've got our cafes. We've got 16 cafes across 6 venues, 7 days a week, running from midday every day. So we've got these spots where people can attend and be part and self-refer and come and ask about mental health concerns. Those are led by our third sector, but we support those with Band 6 nurses and Band 4 support workers. So we bring the mental health services to those venues, and we go wherever the acuity is within those venues. And then within our hub, within our within our phone line model, we have mental health navigators from the third sector and a range of NHFT professionals as well. And this was very much about us being able to have a one-hit model that if someone rang up, they didn't have to know which service they needed. They just got that service, and we decided in the background where it went. Next slide, please. Okay, so the three tiers for us really, we've worked really closely with the third sector over the last 4 or 5 years, and as I said, they've been integral into supporting us with our crisis cafes, our hubs, our hospital at home, and they deliver an amazing amount of service user needs-based care. The stuff that NHS organisations have struggled to deal with over the years, because we've always kept our thresholds very high, because we've always had this concern that if you have a 24-hour phone line, or if you open a crisis cafe, there's an extra 10,000 people in acute psychotic crisis out there who will suddenly ring or suddenly turn up. And I suppose working with the third sector, when we went to them and said, can you open some crisis cafes with us, and how would that look? How would it look if you opened your doors 24 hours a day or into the evening and people could just walk in and say they were in crisis? They said, Adam, you're a fool. We do that all day, every day. It's just you've never helped us with that. And I really think that's true. These organisations are always there. Their front doors are always open, and they're always working with really complex individuals in very good ways. So we've worked alongside them. We've trained those staff. They integrate with our staffing model. And when you pick up the phone and you ring our 0800 number, you will speak initially to a mental health navigator that is a third sector worker. That's not a third sector service that's somewhere else in the county. They're sat in our building with us. Just behind them in the same room are our mental health nurses and our mental health practitioners. But we asked them to make that the first point of contact because we didn't want to make this about high-level psychiatric assessment. We wanted to make this a conversational model where people could have a bit of a chat about what their mental health problems were in the first instance before being moved through a process of needing to speak to a more senior clinician if that was required. And we'll show you how that's worked as we go through in some of the outcomes. So your first point of call will be initial triage conversation. It's not a UK triage tool conversation. It's a very conversational model that looks around a safety plan and just asks people what their needs are today. The second tier is there's a therapy-based tier to it. So there's some band 5 and band 6 nurses that can engage with people who are already in services and already in therapy, who might need some support in working on their therapeutic skills to alleviate a crisis at the time. And then we've got these primary care liaison workers. They're in essence our community mental health team workers that link directly with the GPs. So they've got some good clinical skills. They're used to working with GPs and other professional bodies. They're good at kind of managing referrals, giving advice, getting the referrals back out again, so that they don't need to come through into secondary services. And then we've got some legs. We've got the ability to go out and see people in the crisis cafes, in the hubs. We've got some ability to look at the hospital at home packages. So again, using our third sector providers to support people at home with an overarching model of support from the hub. And I've just had another chat today with our approved mental health practitioners who from the new year are going to co-locate with us in this hub as well, alongside adult social care. So it really will be, when you pick the phone up, you'll get you should get the entire response without needing to ring a multitude of different partners. Next slide, please. So we went 24/7 from the 16th of March. I would love to say that that enabled us to have a soft rollout, which was the plan. You know, you'd like to switch one of these things on and not tell anyone about it, but unfortunately COVID suggested that wasn't going to happen. So we were very quickly working at pace. And for the third sector alongside us, that was eye-opening, to be fair. But the team have absolutely smashed it. They've worked incredibly hard. We've managed to increase our staffing using COVID funds over towards the winter and over the summer period and in towards the winter, and we're seeing the same as other hubs. We're seeing the ability for EMAS to make contact with us via the ambulance service and prevent conveyance. We're seeing the police being able to use it via our street triage if our street triage is off doing something else. As I say, we're able to striate people into these crisis cafes and meet them there if they need. But moreover, what we're seeing is that the third sector are playing a vital role in preventing people sitting on waiting lists within our secondary services. So you'll see we've headed up towards nearly 6,000 calls a month. And the reason we've included the not connected calls in there is that's the reality of setting up a phone line. We assumed that we were going to get about 3,500 calls a month because you don't know until you switch one on. And we know very quickly that we're well above that. But I'm pleased that that gap is stabilising to some extent, and hopefully will continue to do so with the extra support staff that we're getting in. Next slide, please. So really, this is just the final slide, just to say where we're at. So as I say, nearly 6,000 calls, averaging about 190 calls a day. Importantly for me, 42% of those people are new callers, so they're new to either mental health services or systems. And because we've provided that striated model, you can really ring up for any reason at all. Any reason is valid, any need is valid. You know, and this gives us that ability to make sure someone goes away with a bit more hope and control and opportunity they had when they picked the phone up. You'll see there that the killer for me is that 78% of calls supported at that third sector level. That's 78% of people who've rung a mental health line and have had their need effectively managed by a third sector provider in that conversational way. When we first had the cafes running, in the first 6 months, we saw 2,500 people in the cafes, and we were just open in the evenings very early on in the first 6 months. And about 600 of those people that came, because we asked them, said that they were going to, if they hadn't come to a cafe, they would have made direct contact with our urgent care and assessment team, our crisis team. When we went back and looked at what the outcome of that was, through just contact with the third sector in a supportive way, the third sector referred through to our crisis team 1 person out of that 600. It's 599 people who thought their needs were secondary care, but through a bit of listening and validating and an approach that met them at their point of need, we were able to redirect that 599 people, and they went away feeling supported. They may have come back the next day and a couple of days after, but it didn't escalate into crisis. It provides an alternative to GP referrals. It is a self-referral point of access. It's our first kind of formal point of self-referral after the cafes, and it's already proving itself to be an essential part of what happens in secondary care. So you'll see that on the chart at the bottom there, our primary care liaison workers, who were GP referral workers, who had massive waiting lists in the thousands at times, who knew that a big percentage of the people that were on their waiting lists could have been pushed back into care elsewhere within the sector and elsewhere within our community services. You'll see that's dropped straight off at the point that we opened the hub, because that 78% of people were going back out into the community with the help they needed. Pleasingly, it's reduced our referrals into our crisis teams, but kept them steady. So they've not deteriorated. But what's pleasing for our crisis teams is that what hasn't happened is we've switched a phone line on and it's gone through the roof. There aren't huge amounts of crisis there when you switch one of these lines on. In fact, actually, people stabilise themselves really well. And the same there for our plan care, our mental health teams our referrals into secondary services have dropped, and this has allowed us to support the management of services that have perhaps stepped back during COVID. It joins up with our acute liaison teams in A&E. We have got 24/7 teams there, but we can utilise the hub ourselves. And very quickly, and I'm sure you'll all probably feel this as of next week and the week after, A&Es will be asking people to ring 111 when they attend A&E, rather than going directly into A&E if they self-present. And so our hub links up directly with NHS 111, so we'll be able to striate and streamline people that are in need of a service through that model as well. That's really all I wanted to say.
Adam,
sweet.
I think that's an excellent point to end on, Adam, actually, so thank you very much for that. I'd like to redirect you as well to the chat box, because you've got an awful lot of positive comments and requests as well.
Positive's good.
Yeah, positive is good. So thank you very much for that. Our next speaker is going to talk about 24/7 mental health helpline in Lincolnshire. Same rules will apply. I'll give you a 2-minute warning at an appropriate point in time. Thank you.
Thank you. Hi there, everybody. I'm Rachel Redgrave. I'm Head of Mental Health Transformation for Lincolnshire STP and Lincolnshire CCG. And I'm here today presenting my colleague from our Foundation Trust, Hayley Slater. Next slide, please. Next slide, when it arrives, is all about the issues. So what our biggest issue was people not knowing where to go and how to get help. And we had multiple single points of access, different phone numbers for different times of the day, The services were quite fragmented, as was the commissioning. And sadly, the default position seems to be our crisis team. Everything seemed to go through to them. And I think it'd be fair to say that just generally in our system, we had confusion. The next slide, although I'm going to screen share now and just play a short film, because one of the biggest issues that we had, oops, sorry. Sorry. Can everybody see the film or not? No.
Yeah.
You did. You saw it momentarily. Please. Sorry. Try it again. So what we wanted to do was try and inspire a shared vision with all our system partners, so everybody understood what their role was.
Sometimes, things happen in life which can stretch our ability to cope. Maybe it's not one singular thing, but a collection of things or experiences that can lead people to feel overwhelmed. For those beginning to struggle, it can be difficult to get the support that they need to help them cope. We want to change this and improve access to earlier support. The Lincolnshire Mental Health Crisis Care Concordat is a collective of organisations working together. We recognise that problems with accommodation, finance and debt, relationships, addiction, poor access to health and social care services, employment or lack of support are important factors in people having feelings of being in crisis. Our plan is to create a mental health hub in Lincolnshire, which will include a helpline that covers the entire county.
Hello, Lincolnshire Mental Health Hub. How may we help you?
The hub will connect people with a skilled listener who will support all callers and connect them with services delivered by our 12 neighbourhood teams across the county. The support delivered by these teams will help address causes and symptoms of distress through one access point. We wish for the hub to coordinate remote professional advice, either by calling directly or connecting through face-to-face services. This will mean that wherever you are in Lincolnshire, you or someone calling on your behalf can dial one number and speak to someone who will be able to help 24 hours a day, 7 days a week, 365 days a year, and callers will only need to tell their story once. The Mental Health Hub will start its work in 2020. To find out...
Thank you. And next slide, please. So where we've got with that in terms of our vision is that we've now established our mental health helpline. Next slide, please. And what we did is we've put poster, this is an example of the poster and all the marketing that's gone out. We secured transformation funds in September. We soft launched in November, and then we launched our all age helpline 24/7 in March. It's a free phone number. Callers can choose to be anonymous if they wish to. It's delivered by a third sector partner called Mental Health Matters, but is linked to a tier 2 helpline, which is delivered by Lincolnshire Partnership Foundation Trust. All the marketing we co-designed with people using and accessing the services. And at the moment, we're in the middle of a 6-month local radio campaign to promote it. I'm now going to hand over to Hayley, because between November and March, we spent vast amounts of time doing pathway work. And so, Hayley, if you could talk through the pathways, please. Next slide.
Yeah, hi, good afternoon, everybody. So I just want to talk through, obviously, the pathways into and from the helpline. So as you can see from the chart, the pathway into the helpline are calls directly from residents in Lincolnshire, but we also do have a pathway in via 111 and CAS, where we've set algorithms so that appropriate calls into 111 come through directly to the mental health helpline. The helpline itself then obviously offers that emotional support, practical advice and guidance to callers, but they also will signpost people onto either mental health services, so for example maybe our Steps to Change service, which is our IAP service, or to any other wider community services, whether they be statutory or voluntary services. But to do this, they use what we call connector support, which is a continually evolving and updating database and directory of services for Lincolnshire, so that they can easily navigate people to the most appropriate services local to them, wherever they're calling from. And that's really important because then intervention is timely and people receive support early on and directly from their neighbourhoods. Within this directory of service, we've obviously also got our crisis cafe offering, so callers are also directed to that provision if that's appropriate. Another possible outcome from that pathway is a transfer of calls to what we call our Tier 2 mental health practitioners. So these are registered practitioners who are available to take calls that come through the helpline that may have risk concerns or particularly complex needs, or that need more of an immediate response. So those callers will be triaged by our registered practitioners, and then their needs met accordingly, which may be a request for crisis and home treatment response, if it is an immediate response that's needed, or maybe to another mental health team, or signposting on to other services within the community, again via that connector support directory of services, just as they would have if they called Tier 2. In addition to this, the Tier 2 practitioners also provide an advice line offering professional mental health advice and guidance and signposting to wider community services within Lincolnshire. Thank you. Back to you, Rachel.
Thank you. So activity, we're averaging about 1,400 calls a month. We're seeing it increase month on month. In September, we've reached a high of 1,700 calls. The average call length is 6.5 minutes, and plus some handling time. I think what's really interesting, we've seen COVID affect the helpline because we've now got 35% of contacts phoning the helpline more than once a week and sometimes daily. The feedback from the helpline is 70% of those people felt that their well-being was being well maintained or improved. And only 3% of callers are actually escalating into the Tier 2 helpline that's manned by the crisis team. Numbers are small from 111, but in the last month we've had 60 transfer over, and the amount of people that we're increasing to signposting and advice and guidance is increasing month on month. Next slide. I'll skip through these next slides because these are just examples of the sorts of data that we're looking at. So, you know, age, many people don't specify their age and that's okay. The call nature, 2/3 of calls are about mental health and general well-being. Next slide. The next slide will show you calls by day of the week and the age profiles, and you could probably guess, you know, that the younger ages are at the weekend and older ages Wednesday to Thursday. Next slide. Calls by time of the day. So again, we've got your 20-year-olds ringing in the early hours of the morning, and 30-year-olds, and then older age during midday, and it picking up. Next slide.
2 minutes, please, Rachel, if you could. Thank you.
And feedback, well, the feedback's been really, really positive. We've had a few incidents whereby we've had to involve the police or blue light services when people are in real distress or the call handlers are really worried about them. So those, you know, but I think those that you know, counting on one hand the number that we've had since then. And next slide, please. The next steps that we want to do is incorporate this pathway to the ambulance service, and we've got meetings in the diary with EMAS to do that, so they can warm transfer calls from their control room. We already do that with the police in Lincolnshire. We have a nurse in the force control room that does that now. We've got a huge student population in the city of Lincoln. and they're all on a digital platform. And what we've now got is a chat bot that the students are using, and we're about to connect that to the helpline. So if somebody's using a chat bot and they want to go through to a human contact, it will be the helpline that will deliver that. And that's, I think, all I wanted to say. I'm sorry it's been a bit rushed. Thank you.
Thank you very much, Rachel. That was excellent, and thank you for keeping the time, and apologies for the intervention. Now I'd like to bring on next speaker, talking about focusing on a training for adult crisis staff. Thank you.
Good afternoon. Thanks for having me. I'm aware of time, so I feel pressured that this is going to be a bit rushed. So I'll try and keep it as brief as I can. Next slide, please. So we were obviously given the task to organise training for all age practitioners supporting children and young people in mental health crisis. We already had the crisis input and support line in place from 8 in the morning to 8 at night, but obviously the challenge was then to do the overnight. Next slide, please. So just to give you a little bit of an overview about Solar, it's CAM's mental health service between Birmingham Solihull Mental Health Foundation Trust, incorporating Bernardo's Autism West Midlands, and it provides mental health input and emotional well-being for young people and families, children aged between 0 to 19. Next slide, please. Just a little bit of an overview, if you can see any details on here, it sort of demonstrates the tiers that we have within the whole service, right from liaison from the GP surgery up to the crisis team and tier 4 beds. And we're the Solar CAM service is all under one roof. We're all in the same building, so we've got a seamless attitude to young people's care and transition to other services within the wider service. Next slide, please. So the Solar Crisis team was set up in 2017. It's a nurse-led service. I now have 4 practitioners and an ASD specialist. As I said earlier, we operate from 8 AM to 8 PM, and we're within the we're co-located with the rest of Solar services. We work very closely with A&E departments, police, schools, and social care. Next slide, please. Why did we look to upskill adult crisis team staff? Well, we needed to get this organised quite quickly. The pressures were there to get this up and running. And we did trial within our own work force to provide the service ourselves, but over a 3-month period, it didn't actually seem there was such little need for us at that time in that 3-month period that it didn't seem financially sort of viable for us to use our own staff. So we felt if we already used the staff that were in place already, that would be a good way of using and upskilling adult staff. Next slide, please. So we looked what we looked at was how can we offer that training? It was right in the middle of the sort of COVID. How are we going to do this? So a lot was done over Microsoft Teams, which has been invaluable for us all. And that was, we looked at strengths and weaknesses, what people needed knowledge about. We looked at role plays, scenarios, calls that may have already been held and discussed and reflected on what was helpful to that young person and their families. We looked at feedback from young people. What do they find that is helpful when they call up? What do they need at that time? What do parents need? And quite often it was about having that person listening, letting them offload, let them talk about how their day's been, what their child is doing, and giving them space and time to just sort of reflect on their day and how well they actually are trying to manage really difficult situations. Next slide, please. So from the training that was held, we did see that there's some anxiety in regard to autism and learning disabilities, the process of admissions to hospital, listening to emotional distress, and understanding the thresholds and the pathways between adult and child services. And also there's the differences between CAMS services across Birmingham and Solihull, and we didn't want for young people to get lost in the system, so to speak. And there was some anxiety about saying the wrong thing to parents when they're very emotional. There was anxiety about making the situation worse. Next slide, please. So the training offer was to staff that already had, they were already mental health practitioners. They already had a wealth of experience and knowledge. And we looked at strategies and skills that they could use to best engage young people and families, which by and large they already had. It was more about boosting their confidence and making them feel confident when taking these calls. And just reiterating that young children and young people don't exist in isolation, they're part of a family. So again, it was looking at supporting the family network and the carers that were involved. Next slide, please. As I said earlier, we looked at case examples and scenarios and explored what interventions and information was offered, making young people and family feeling empowered. Actually, they've done the best thing is to ring us rather than things becoming a real crisis and escalating. And staff had the opportunity then to talk about what their anxieties could be in calls and how they may manage it. And we looked at different sort of interventions that we could use for best practice. Next slide, please. Information was given, so they had up-to-date information regarding our pathways for children and young people. So that would be like GP catchment areas. That would be information regarding all our resources that we offer to young people and families that can be found on our SolarCAMS website. Next slide, please. Again, we made sure they had, like I just said, all the apps that young people could use, all the forums that are available to young people and parents and carers. So they had full access of giving out a full resource pack in terms of signposting and, again, empowering the young people and the families to receiving the right help at the right time. Next slide, please. And that's more information that we give to make sure that they've got all the networks and apps. Next slide, please. And we will have done and continue to offer supervision for the out-of-hours staff and ongoing advice on any queries or pathways or thresholds. We all use exactly the same recording system so that they can access any call they receive. If they're open to services, they are able to easily access any history, any current role and any current involvement with other mental health services. So it's very seamless in terms of retrieving that information. And we have CAMS have a one-line central email inbox for any handover information. So we, again, as a service, we can follow up any calls that were received out of hours.
2 minutes, please, Emmeline, if possible.
No problem. And our next step now is just to receive the feedback and evaluation and look at data. Thank you very much.
Thank you. That was a super quick 2 minutes. Now on to our next speaker, talking about impact. Thank you.
Hi, good afternoon. I've just put something in the notes, the chat. Like others, I need to leave at past. for another meeting, so not sure whether we want to go ahead with this one today or roll it over to a future webinar.
In that, if you have to go, then that's absolutely fine. I think what we'll do is, as long as you're okay with it, we'll put the presentation out with the information that we gather from today's session. And if anyone wants to get in touch with you for further detail, they can. Would that be okay?
Brilliant, no problem.
All right, then thank you very much. I apologise for not keeping everyone to time.
No problem.
Thank you. And Nick, are you able to step in?
No, I've got to go as well now, I'm afraid. So the same applies.
Okay. In that case, then, similar case, can we share the presentation?
Please,
if you have questions, they can get in touch with you.
Yeah,
thanks very much. Okay, so that means all of a sudden we've reached the end of today's session. So thank you very much for everyone who's taken part, to all the speakers. Thank you very much to Dave, who's been doing the presentations in the background, as well as to Jenny, who's been monitoring the chat box. The presentation, the whole recording, the whole event has been recorded. That we made available to everyone. As well as that, Jen will put together a sort of frequently asked questions Q&A based on what's gone on in the activity within the chat box. So for now, it just leaves me to say thank you very much for your time. I hope to see you all at a future event. Thank you.
Thank you, Ian.